Good night, sir. How are you? My name is Mario Lopez. I'm going to be taking care of you today, okay? I'm going to be your nurse practitioner. So today we're going to be doing the assessment of the heart, inspection, palpation, auscultation. First thing, we take a vital signs. A blood pressure should have been taken. Sitting supine and sitting with after 5 minutes of the patient being rested. After that is done, this is the best we could do. So we have the patient on the exam table at a 45-degree angle to be able to assess the jugular venous pressure. So I'm gonna incline the patient more or less to a 45-degree angle. That's my here. So after you have it in a 45-degree angle, you need to look for the pulsation of the interior jugular vein. Can you please turn that way, sir? So you're gonna look in the neck for the internal jugular vein. You're gonna look for the pulsation. And this patient, I can see the pulsation right above the suprasternal notch. So we're gonna be measuring horizontally to the highest point of the pulsation, and then we're gonna measure from the suprasternal notch, making a 90-degree angle and measuring it. Perfect. So it's 2 centimeters. So normal should be below 3. Anything below 3 or 3 or 4 should be normal. So in this case, it's normal. The jugular venous pressure. So after we finish taking that measurement, we're gonna go ahead and inspect the carotid obstruct. So we're going to be looking on one side, we're going to be looking on the other side of the carotid. Now we're going to go ahead and palpate the carotid pulse. We're going to feel for the amplitude, for the regularity. The other side too. One at a time. We never check the carotid pulse both at a time because we could occlude blood flow to the brain. We're going to feel for any thrills. So the same thing we're assessing, we're palpating that pulse. We're going to listen for any bruits. Listen for any bruits in the carotids with the bell of the diaphragm. With the diaphragm for the stethoscope. That way, please. And sometimes you can tell the patient to hold the breath and be able to hear better if there's any bruits and not confuse it with any breath sounds. Can you please hold your breath? Okay, the other side. Can you please hold your breath? Hold your breath. Okay, I did not hear any bruits, and I did not feel any thrills in the carotid. So we're going to continue, and now we're going to inspect the chest wall for the configuration. We're going to inspect the sternum. We're going to inspect for any pulsations throughout the chest wall. We're going to inspect for the pulsation at the point of maximal impulse, which should be left the sternal border, 5th intercostal space, the left midclavicular line. So it should be around right here to any the apical pulse at the point of maximal impulse. I did not see anything. Of course, and for the purpose of this exam, the patient has a shirt on, but the patient for the examination should have the shirt off. You need to be able to assess the chest properly. So after you inspect it for the pulsation of the chest wall and look for the point of maximal impulse, and you will of course assess the skin and any lesions that you might have. You are gonna now go ahead and palpate. So for palpation, we're gonna be palpating for any lifts, any heaves, any thrill throughout the landmarks of the heart assessment. So with the base of your hand or with your tips of your fingers, 2-3 fingers, we're gonna be palpating at the aortic pulmonic left sternal border into the Erb's point and then to the point of maximal impulse. So the right aortic, second intercostal aortic landmark, second intercostal space, right to the sternal border, and then we're going to go to the left sternal border, second intercostal space, to the pulmonic, and then we're going to go down the sternal border inch by inch, third, fourth, and fifth intercostal space, left sternal border, Erb's point, and then you're going to go left, the left mid-clavicular line for the point of maximal impulse. We're gonna palpate it, we're gonna feel, and we're gonna measure the diameter. Should be around the size of a quarter. If you cannot feel the point of maximal impulse in this position with a patient at a 45-degree angle, you can always ask the patient to turn to the left and be able. It's easier to feel it that way. After you palpate all that, and then you can palpate for any pulsations. We're gonna now we're gonna go ahead and auscultate. For auscultation, we're gonna use our stethoscope. We're gonna auscultate in the same areas that we palpated with the diaphragm, and then we're gonna turn around, and for the bell, more high pitched sounds with the diaphragm and more low pitched sounds with a bell. So we're gonna go ahead and start. When you are listening for heart sounds, we're gonna be identifying the cardiac cycle, beginning with S1 and S2, and identifying any murmurs, any clicks, any extra heart sounds, any S3s, any S4s. So I'm gonna be the areas that you're going to be auscultating is going to be in the second intercostal space to the right, it will be the aortic, and the second intercostal space to the left of the sternum will be the pulmonic, and then down the left sternal border and third, fourth, and fifth intercostal space and Eric's point, and then you're going to go to the left, the mid-clavicular line to the apical pulse, point of maximal impulse. There's also in young adults and in kids, we hear an S1, S2, S1 is created by the closure of the atrioventricular valves, the bicuspid and tricuspid valves. The S2 is created by the closure of the aortic and the pulmonic. The splitting of the S2 means that the pulmonic is closing after the aortic valve is closed, and that happens because of differences in the intrathoracic pressure. So whenever somebody takes a deep breath or inhales, the thoracic pressure decreases and there's more feeling in the right side of the heart, and that's why it creates an after closure of the pulmonic valve. So I'm going to ask the patient to, can you please take a inhale and take a deep breath? Again? Again? Okay. I do not hear any splitting of the S2. After we're done with the auscultation, inspection, palpation, auscultation of all heart, we're done. Thank you very much.